Welcome to FastFacts. I'm going to pull up the slides and then we'll get started here. Thank you everybody for joining. I am Hilary Spencer. I'm the Infection Prevention Medical Advisor at IDPH, and we are presenting What's Hiding in the Pipes and Drains, Healthcare-Associated Infections Due to Legionella and Other Waterborne Organisms. And I will let my co-presenters introduce themselves before we start. Judy?
Good morning, or good afternoon. Hi, I'm Judy Karoff. I'm Section Chief of Communicable Diseases here at IDPH in the Division of Infectious Diseases. Brian?
And I am Brian Cox. I'm manager of the Plumbing and Water Quality Program in the Division of Environmental Health at IDPH.
Great, thank you. A few housekeeping things first. This is the CME accreditation statement. You'll get more information about that later too. And financial disclosures, we have all three of us have none, no financial disclosures. Another housekeeping note, webinar sessions are recorded and shared with all participants. Questions during the webinar should be entered into the Q&A option, where the presentation team will provide responses. To access the Q&A function in WebEx, select the three dots on the right-hand bottom of the WebEx screen, and then click on the Q&A option. It should be the first option to open the Q&A window. A post-webinar survey is also available to attendees for 7 days after the session. Those who attend the webinar and complete the survey are eligible to receive a certificate of participation or continuing medical education credit as appropriate. All right, this is just a quick glance at our overview and objectives. The learning objectives you can see here on the right, and just for a brief overview, we'll be covering a clinical overview of Legionella. Judy will be talking about Legionella epi and cluster detection and the epi response. And then Brian will be talking about the response from an environmental health perspective and then water management more generally. And then we'll end with a little overview of other waterborne infection risks in healthcare before taking questions. So diving into Legionella, as a reminder, Legionella is a gram-negative fastidious intracellular bacteria. It's a lot of detail that sometimes we lose track of over time, but the particular reason that I want to point that out is because there are a couple things to anchor to on that. So because it's a fastidious organism, you can think this is difficult to culture and you need selective media. That's really important when you're thinking about diagnosis. And because it's an intracellular bacteria, you can sort of anchor to that and think about atypical pneumonia, and that sort of influences antibiotic choices. And we'll wrap back around to that as well, but just want to sort of point those things out as sort of anchor points. We're going to be spending most of the time talking about Legionella pneumophila here on the left, but I want to make a brief mention because this really comes in when we're thinking about water management and what have you. So you'll hear more about this later, I think, too. But Legionella non-pneumophila on the right are all other species of Legionella. There are more than 58 species, and some examples include these funny names that I'm probably going to mispronounce, but Longbeachiae, McDadii, Boesmananae, I'm totally butchering these, and Dumothi. These are just a few examples, but there are more than 58. Most of these don't affect humans, only about half infect humans, and even those infections in humans are not common. But we're going to spend most of the time talking about Legionella pneumophila here on the left. And within the species of pneumophila, there are 16 serogroups. So there's even more sort of subdivision. And this is important because serogroup 1 accounts for 65 to 90% of Legionella or Legionnaire's disease cases, for which there's a bacterial isolate for those that we know about. And this is a little bit different in different regions. There are also some regions of the world where non-pneumophila species may be more common, and there are some places where other serogroups of Legionella pneumophila are more common. But in our region of the world, serogroup 1 of Legionella pneumophila is most common. And this is important to think about and to remember and sort of anchor around, because the urine antigen test only identifies serogroup 1. So that's sort of the clinical significance for that. So diseases and manifestations caused by Legionella pneumophila. We're just going to briefly mention extrapulmonary legionellosis, just so you know and remember that it can happen. In children, it can cause liver, spleen, and brain manifestations. Those are pretty uncommon, and still uncommon, in adults, but more common in adults. can be endocarditis, graft infections, joint infections, and cutaneous or wound infections. All of these are pretty uncommon, but just sort of for awareness, those can happen. Pontiac fever is one most people have probably heard about as well, but still sort of a less common manifestation or less frequently identified. Pontiac fever is a mild self-limited infection. There is no pneumonia associated with Pontiac fever. It does cause a flu-like illness with fever, headache, myalgia, and weakness. And is probably not diagnosed as often as it occurs because it's really very similar to other febrile illnesses and not always appreciated. Maybe more appreciated when there's a cluster that have a common and unusual source. But it's self-limited, so we'll kind of wrap back around to that as well. The implications for the population and from a public health perspective are a little bit different. And then Legionnaire's disease, the manifestation for which Legionella is named, and we'll dive into that. So when to suspect Legionnaire's disease? Symptoms include pneumonia, and that's really the hallmark for Legionnaire's disease. This can be a clinic and or radiographically diagnosed pneumonia. And a couple of notes about that, things to sort of think about, kind of anchor around. Pneumonia that is occurring in someone who's failed therapy for community-acquired pneumonia, especially if they were treated with a beta-lactam or other antibiotics that don't cover Legionella. So we thought about those atypical bacteria and the antibiotics that treat that. Beta-lactams like the amoxicillin and other penicillins and cephalosporins don't cover Legionella. So if somebody has a pneumonia and they're not responsive to sort of usual treatments, that's a sort of a note to make you think about or consider Legionella in your diagnosis, in your differential. You also think about pneumonia in an immunocompromised host is another sort of anchor point, pneumonia that's in a subpopulation that's more at risk. Fever, chills, cough, and chest pain can be a notable symptom. Progressive respiratory distress, and with that, think about quick progression to the ICU. These are usually folks who are pretty sick. This is a little bit different than sort of slower, sort of progressive pneumonia. Headache, myalgia, nausea, diarrhea, abdominal pain, altered mental status, and renal manifestations can all be seen with Legionnaires. So pneumonia, in addition to these other symptoms, are things to sort of spark that thought about whether you should be working up for Legionnaires. You also think about Legionnaire's disease in those who've had exposure risks. Travel, particularly cruises, have been associated with Legionnaires or exposure to water features. Healthcare-associated infections, so new onset pneumonia more than 48 hours after an admission may spark consideration for Legionella. And pneumonia onset in the setting of a Legionella outbreak. So if that's a community-associated outbreak or in a healthcare-associated outbreak, if an outbreak has been observed and you have folks that are being diagnosed with pneumonia, you should really be working that up for Legionella. Host risk factors are important to consider as well. Legionnaire's disease is uncommon in otherwise healthy folks. They may have Pontiac fever if they're exposed to Legionella, but Legionnaire's disease is uncommon. So host risk factors include a current or former smoker, individuals who are of older age, particularly over 50 or even older, cancer, other immunocompromising conditions, chronic lung disease, diabetes, kidney failure, and liver failure. So yeah, this was another anchor point. Think about pneumonia particularly in long-term care residents where there's been a recent Legionella investigation should really be worked up. Okay, a few notes about diagnosing Legionella. When you're thinking about working up Legionella, you should be thinking about both a Legionella urine antigen test, or UAT for short, and Legionella culture of sputum or other lower respiratory specimen. We really want you to think both, and a UAT and culture. And the reason for this are several. So remember that point that UAT only identifies serogroup 1. So if you're doing a urine antigen test, you're only identifying serogroup 1. And with culture, think that selective, that difficult to culture, that it's fastidious, and that you need selective media. So it's really important to remember this because you need to order a Legionella culture specifically so that the lab can work it up appropriately. Just a routine culture may not be handled in a way to identify this. So you really need to notify the lab and order it correctly. These tests are important to do in combination. Additionally, because they have different sort of features. So a urine antigen test is rapid, so that can help guide treatment and what have you more quickly. And it's more sensitive than culture. You can see in this table here that the urine antigen, when we're thinking about serogroup 1, so it's only useful for serogroup 1, but captures 70 to 100% of the time. So it's very sensitive, as opposed to culture that is only positive, 20 to 80% of the time. They're both very specific, but culture, because it can be difficult, is not always positive. But culture is important because it can identify all species and serogroups of Legionella. So serogroup 1 is still most common, but there can be other serogroups. So if you're thinking about Legionella, you want to be able to capture those others that may be causing disease as well. Additionally, and especially from a public health perspective, clinical isolates are critical to determining links among clinical cases and with environmental sources. So with a clinical isolate, with that culture, we can do sequencing and identify the relationship to other cases, to other people who have Legionella, as well as to environmental sources. And that can be particularly important for a very mobile population that may have multiple different exposures. And because Legionella is so ubiquitous in the environment, so common to find when you're looking in the environment, that it can be really important to have those sequences to be able to say with confidence that these are related. And just a quick note about treating Legionella, and this takes us back to that other anchor about thinking about being intracellular and thinking about atypical pneumonia and antibiotic choices. So azithromycin and fluoroquinolones are the workhorses of treatment for Legionella inpatient, and as step-down therapy, doxycycline may also be substituted for oral step-down, although it's not effective against lung BTA, which we don't see much of around here. And then as a reminder, Pontiac fever is self-limited, which means no antibiotics are recommended. So for antibiotic stewardship purposes, just a reminder that Pontiac fever resolves. All right, now I'm going to hand it over to Judy to talk about Legionella epi and the epi response.
Thank you, Dr. Spencer. So let's look at a timeline of the number of cases that we typically see in Legionella over time, looking back from 2010. As you can see, the number of cases that we've seen here in Illinois has increased. And the next slide, I'll talk a little bit more about why that is. But we have escalated from low 150 cases like we saw in 2010 up until our peak year in 2019 of 615 cases. And during that year, that was a huge increase over what we had historically seen. And at that time, other states were also seeing an increase, and Illinois participated in a couple of studies, one with New York looking at climate and other factors that might have caused an increase. But we have have yo-yoed a little bit. 2020 was very similar to what others were seeing in healthcare of diagnoses other than COVID. We suspect that there were potentially some Legionnaire's disease cases that were co-infected and didn't get recognized as Legionnaire's disease. And we know that people weren't out and about as much, probably had more of a factor on limiting the number of cases that year to get exposures through travel or other means. So that COVID effect decreased our numbers in particular in 2020, but we bounced back in 2021 with another record year and then have leveled off since then. So next slide. And this is a study I referenced just a minute ago. They looked at, in this study that was published in NIH, they looked at all kinds of articles that have been written on this topic. As I mentioned, a couple that Illinois was part of. and brought together all of that research to try to summarize why we've been seeing an increase in Legionnaire's disease cases over time. Next slide. So I summarize those for you here in this slide, but definitely over time we've been seeing that increase, and this increase has been steady, very similar to what you saw in the Illinois graph, and they average at about 9.3% each year, excluding the anomalies that have increased and decreased our numbers. In particular, the Mid-Atlantic states and the Midwest regions have had higher rates of increase. Legionellosis is the leading cause of all waterborne outbreaks in the US, and I'll talk a little bit about what types of outbreaks we've experienced here in Illinois. But those are very rare. Most of the time, we don't link cases together and able to cluster on outbreaks. Legionnaire's disease or Legionella itself is ubiquitous. We tend to think of it in those terms as that you could walk by a building, a fountain, and be exposed, and it's very hard for us to link back as we do when people eat a particular food item or a particular restaurant. It's easier to cluster on that type of a disease than it is for Legionnaire's disease. But most of our cases, as I said, we consider sporadic. Most cases, as the study found, and what we see in Illinois, are sporadic and community acquired, though we do track quite a few healthcare associated ones I'll talk about later. But what the study found and what we suspected in our years where we had really high cases is that precipitation may have been a major driver, temperature change, climate change, humidity, all which I anticipate Brian will talk a little bit more about how Legionella can amplify in our water sources with heat, likes to grow at hotter temperatures. And so when all of those factors come present, it provides that opportunity for Legionella to expose people when situations that are in place to prevent might fail. And that's generally what we see. There was some look at as our population is older, is that causing some increase? And that could be, as Dr. Spencer said, persons that are older in years are more likely to become infected or to develop disease. And those are the ones that we catch. Tip of the iceberg, as we like to talk about in public health, we are identifying those that have been exposed that develop disease, which is typically those that have those risk factors that Dr. Spencer went over. Next slide. So here's a look at the seasonality of Legionnaire's disease. As I mentioned, Legionella likes to grow and amplify in hot weather, and people are out and about more and travel more in hot weather. All those help to increase the number of cases that we see seasonally in the summers and early fall. So that's been pretty consistent. You'll see this blue color, almost tealy color, is July, which is our biggest month that we see, and then it stays in August and September pretty consistently. Next slide. And this is just another look at the seasonality to really show you how July peaks. And as that article showed, there are years where we've had a hotter early spring or a hotter summer with more rain and more precipitation. And we think probably those are the contributing factors when we see particularly large years. None of these increases are attributed to any large size outbreaks. I looked back through our history of outbreaks the other day, and in more recent years, probably the last 5 years, our outbreaks have been limited to pretty low numbers in the single digits, or maybe 13, I think is the most we've seen in a really long time, as compared to earlier years where we saw a lot of, we had even I think over 100 cases at one point with a very early I think it was 2002 outbreak with a hotel fountain. Next slide. Majority of cases do become hospitalized. Again, it goes back to what we've been talking about and Dr. Spencer talked about, is those at highest risk are older, already have immunocompromising conditions, and Legionnaire's disease causes pneumonia, which most people then end up being hospitalized for treatment of that. But ranging from 93 to 97% of our cases do become hospitalized. And in terms of deaths, our deaths have ranged over time between 6% and 11%, with 11% occurring in 2020, interestingly. Next slide. Here's a look at the state, our state map in terms of where we see cases, and this is just based on case counts. It's not quite as impressive as if we would do rates, but it shows the same picture. Larger cities are going to have more cases. We really don't see any area outside of just larger metropolitan areas having higher case counts. We have investigated recently a few clusters, one in Madison County, one in Peoria, one in Will County, where we see cases and they live geographically close to each other. And we do then, once we see that, we'll investigate, even re-interview, ask our local health departments to re-interview, look at places of employment, places where they've traveled, anywhere that they have been, and try to pick up and cluster anyone around there. As much epi information as we can collect to try to point to a source and provide that to our environmental health team to investigate. We also like to look at onset dates too. With Legionnaire's disease, we think of a really long incubation period or exposure period of a 12-month period. Part of that is because this disease, as I showed in the last slide, can cause people to be severely ill and cause death. And so we consider, if someone has been at the same place within a 12-month period, we consider that an outbreak. And it speaks to the health of that water system. If we've had two people that have been sick with that exposure, then it's likely that exposure caused the illness, and we need to act and intervene with that. So next slide. I'll talk a little bit more about outbreaks here in a minute. Males are more likely to develop Legionnaire disease, at least in terms of the Illinois experience. It's been very consistent over time. I was looking at a couple factors, and I've never seen any good data on why this is. Males tend to smoke more than females. It's just a little bit of a percentage, shouldn't really cause, I think, this level of increase. Males are typically outside more, and sometimes some of the exposures happen outside. But we're pretty consistently see between 62 and 68% of our cases in males. Next slide. This is a look at age. As Dr. Spencer said, most of our cases are in the older population, and that's very consistent over the years as well. Persons starting at age 50, you can see, are consistently the younger population is just not impacted from it. And if they do become exposed and infected, they generally have more mild illness like Pontiac fever, and we rarely catch those in healthcare. The illness is very mild. It's really only when we have an outbreak and we know of cases that we find additional cases that might be close contacts or are aware and can say, yeah, I did have a respiratory disease as well. And I had that same exposure. But consistently over time, older age populations are impacted. Next slide. As Dr. Spencer was saying, there are different species and serogroups of Legionella that make people sick. And as she said, Pneumophila serogroup 1 is the one we predominantly see. It's largely because that's the one that the urine antigen test picks up, and that's almost exclusively what we see diagnosing. But we have had McDaddy, some cases there, Long Beachy, we've had a few cases, in Basmani as well. But by and large, a large percent is either Legionella Pneumophila 1. We do see sometimes it's cultured just to Legionella and we don't have a serogroup, or it's to Pneumophila but not serotyped. Next slide. Oh, we did have an outbreak of McDaddy in the 2002 cases, or 2002 outbreak associated with the hotel spa, which was kind of interesting to bring up. And I don't know, really have a theory why, but we did see, and maybe there was more culturing done in earlier years. But when I look back through the data, we did identify more different kind of serotypes, serogroups in earlier years than we have been in more recent years. Next slide. So how do we find clusters? So first, we're always looking geographically. And so this is not very fancy, but it's the report that we look at weekly and track it generally by region. And if we see something that's looking unusual in a region, we'll look a little deeper. And so this is the Edwardsville region, which is considered the Metro St. Louis area of Illinois. And you can see that in June of 2019 and then also again in 2025, they were way above baseline. And their baseline we calculate based on a 5-year median. And so normally in June, then we would expect them just to have a couple of sporadic cases. But we started noticing an increase there probably by July, and these are based on their onset date. So we're generally a bit off on the based on the time it gets reported of the onsets we're looking at. And so we started looking into this and found three of actually that were from the same town, and then started seeing additional cases getting reported from that same county, maybe not as closely linked. We were not able to find any solid epi links there. We did send out a health alert to clinicians in that area, asking them to be on a heightened suspicion for Legionnaire's disease in patients presenting with pneumonia, and to try to more actively find cases and find where they were getting exposed. But we weren't able to find a link there. I do think 2025 and 2019 weather-wise were fairly similar. And so that could have contributed to it as well. Next slide. The other thing we look at daily is certain areas where we know we'll see clustering and where we know we have populations that are at high risk for disease and will have more severe health outcomes. So long-term care facilities are top of mind for us, and looking for cases that are identified in a facility. This is great information that we might get from the provider. So if you ever know that someone lives in a long-term care facility, if that's part of your reporting to us, that can be super helpful. Our new system will actually look at the address and identify whether it's a congregate care facility for us, so we'll know right away. Most of our locals are pretty trained to look up an address and make sure it's not long-term care facility as soon as they get your report. And then we look to just eyeball the report every day and see if they've had a case within the last 12 months, and the red ones would represent new ones. We have other information in this, age and the name of the facility, that I've not put in here just to avoid disclosing any information that's not necessary. We'll look at hospitals, we'll look at other healthcare exposures. As you can see from the tabs at the bottom, we look where people work. And so we might have somebody that works at a long-term care facility and then also resides there, and would put those two things together. What you can't see on here, we also look for Illinois hotels, people that have had stays at Illinois hotels. We even look at grocery stores. We had a little bit of a suspicion about a mister in a vegetable or a produce section that we investigated, but keeping those on our radar as well. Some of our larger local health departments, and when you have more densely populated areas, you can use some geographical software to help you find your clusters. And I know that's something that the City of Chicago does, and we have done in the past as well. But when you have not quite so dense of a population, it just isn't very useful. Next slide. So as we've mentioned before, we really think of outbreaks in three buckets: travel associated, community acquired, and healthcare associated. And as I mentioned in the last slide, healthcare associated is really the one that we're most sensitive to due to the vulnerability of that population and the risk of severe disease. And so if we find a healthcare facility where someone has never left, and those are generally your congregate care, long-term care facility, developmental disabilities facility, even a homeless shelter, and someone hasn't ever left there within a 10-day period in their 14-day exposure period with 10 days consecutively, we do an investigation, which I'll detail the steps we do in that investigation here in a minute. And so we will label them as a presumptive healthcare exposure and investigate those. We're actually doing one this afternoon, getting on a call with the facility to understand more about what's going on there. And we will send our staff on site, and Brian will tell you all about what they do then. The ones that are more difficult to investigate are the community acquired ones. And those are ones where there's not an obvious link. As I said, it's not as easy as you ate at the same restaurant or you ate the same food, but it's people that you can link that they've been at the same place. So we've had some pretty interesting ones in the past. Probably our most interesting one was a baptismal fountain. So it was a fountain that they used in a church, but also is used for baptisms. That was probably one of our more interesting ones. We've had hotel swimming pools. And what's helpful there is that we get information from other states when they have an Illinois exposure, and we add that to our system so we can cluster on the same travelers that have been to our hotels. And then we'll do a different investigation. We've had what we've suspected to be a cooling tower investigations or cooling towers. And generally when it's a cooling tower, we'll see our epi curve be pretty tightly clustered. And so we get a bunch of cases that report a very similar onset date. And then and there's no other connection, and they didn't travel, and they weren't in a healthcare facility. Our suspicions rise for cooling towers. And I'm sure Brian will talk about what we do in those situations. Next slide. So what do we do when we identify there's an outbreak or a single case in a healthcare facility? The first thing we'll ask you to do if you're a healthcare facility, a hospital, long-term care facility, is to look back at the last 3 months. Have you had pneumonia cases that have occurred and are above your baseline as suspected additional cases that we would probably put on our line list as suspect cases that had pneumonia, especially if they were hospitalized? As my slide showed, most of our cases are hospitalized. So we're mostly concerned if there were patients that had pneumonia and which required hospitalization. We will actually try to get, if there's anyone currently in the hospital, make sure that they're being tested for Legionella with the testing that Dr. Spencer mentioned. Then we'll ask the facility to start a line list, and it's a pretty extensive one where we ask for onset date and symptoms and where they live and what floor they're on, what room they're in, where do they shower, what other things have they been doing, do they aspirate, are they drinking water with ice, all kinds of questions to try to identify potential exposures, but also when we have cases that are suspect, try to get at, could they have had Legionella? What were they treated with? Did they respond to treatment? As Dr. Spencer mentioned, we know that certain antibiotics are more effective at treating Legionella. And so looking at that as well to try to understand who could have been a possible case, and as many as we can confirm as cases helps our epi investigation. So we do all of this to try to give good information to our environmental health team so they know where to go look and identify where the potential source or sources could be, and then to recommend control measures so that we can prevent others from getting sick. And so in addition to the line list, all those persons that could be suspect cases, we'll ask for them to be first screened for pneumonia, and then if confirmed with pneumonia, to be tested for Legionella. And so the rest of the steps here, or the next 3, will be generally performed by our environmental health team. So I'll wait for Brian to talk about those. We generally get involved in making sure the facility is communicating with their staff and with their residents and their residents' families that there has been this exposure. And then we'll work to, if possible, most of the time in these situations, we have people that have had urine antigen tests, but maybe not culture. So if anybody is currently hospitalized, we'll work and see if we can't get a respiratory specimen to test. And if we can isolate Legionella, we'll have our lab do whole genome sequencing so we can connect cases that way. But then also if we sample in the environment, we can also connect those two specimens together and see how related they are by whole genome sequencing. Next slide. Just a couple more for me. When conducting clinical surveillance, I'll just kind of go over this really quickly. I think I've talked about most of the points, but we do a pretty intensive look back and look forward when we're conducting surveillance, working with infection control and clerical team to identify anyone who's had recent healthcare-associated pneumonia, checking to see if there was testing performed. Daily, we recommend performing temperature checks and screening of other residents, especially if we've identified a particular wing, and any that I have identified with fever or any respiratory symptoms to look for pneumonia, and if there's pneumonia present, to test for Legionella. We do not recommend, and I think I saved this for the next slide, but just screening for Legionella without the presence of pneumonia. It can be very confusing. Legionella can persist in the urine for generally around 3 months, but could be up to a year. And so we've certainly, probably more regular than we would like, get confusing cases where somebody might test positive, especially if it's in the absence of any clinical symptoms. When was their onset? Was this current symptoms we're seeing related to a recent infection, or are we picking up from a past exposure? And I think I probably talked through all of this. So next slide, my last slide, I think. Recommendations for Legionella testing when you're in an outbreak. Again, we don't recommend just screening everyone for Legionella. I think that's the thing where we go two ways, really. One is there's over testing and then we get confusing cases and we're not sure, and they probably confuse the investigation more than help it. Or we do really well for a week or 2 weeks, and then a month later, we check in with the facility and find out they've had cases hospitalized with pneumonia and nobody was tested for Legionella. So the amount of time where we want facilities to have a heightened suspicion for Legionella varies, and it varies based on what we're seeing with environmental testing. If we're consistently still finding it in the environment, then this could persist for quite some time, that we would want you to be testing more aggressively and systematically for Legionella, according to the guidelines here. So I will go ahead and switch to Brian so that he can go over all his information. Thanks.
Thanks, Judy. You can go ahead and go to the next slide. And so I am going to go ahead and talk a little bit about environmental health response as well as water management programs. And so the IDPH Division of Environmental Health, what is our role in terms of environmental health response to cases of Legionnaire's disease or other opportunistic premise plumbing pathogens? It's to investigate the environmental factors associated with those, to assess water management practices of the healthcare facilities during those investigations, to conduct plumbing inspections to determine underlying conditions that may contribute to those opportunistic premise plumbing pathogens. And also, the purpose of the investigations is to ultimately identify a source of contamination and then take action to prevent additional illness. We'll highlight safety gaps in the water systems or ultimately identify strategies to reduce the waterborne illness. And I'm going to take a second to point out that photo there. So you can see that there is a point of use filter that's been put on that faucet. And the only reason I want to point this out is because you can also see that there's a line for a date. And that on this particular photo, there is no date. And so I'll address that a little bit later, but since I didn't include this photo later, I wanted to at least make a point to call that out. Next slide, please. So what are opportunistic premise plumbing pathogens? Legionella pneumophila is one of them, Pseudomonas, Mycobacterium, Acinetobacter. There's a longer list of these. These are just some of the examples of ones that we've identified and that we have investigated in the past. They are microbial residents of the water distribution systems, essentially meaning that they're growing actually within inside those pipes and within inside the water distribution systems themselves. So unlike other waterborne pathogens, they're native to that premise plumbing system. And so it's not necessarily a contaminant coming from the outside in. It's a contaminant that has already been introduced and is now growing on those pipe walls themselves. Next slide, please. Common characteristics are that they are disinfectant resistant, they're thermal tolerant, biofilm forming, they're intracellular, so they grow within amoebae. They grow at low organic carbon concentrations and grow under conditions of stagnation. Slide. So the one that we're going to focus on right now, and that most of this presentation has been surrounding, is Legionella. I think Dr. Spencer's already given a pretty good background on Legionella, so we can go ahead and just skip to the next slide. So how environmentally do we, or why are we concerned with this? As it's been noted, Legionella is ubiquitous. It's found in lots of areas of our environment, specifically within naturally occurring within freshwater environments. That could be surface water, it could be groundwater, it could be within soil. But really when it becomes an issue is once it's entered the artificial system, so building water systems, when other factors are being applied to that, then the Legionella can amplify within those systems. Ultimately, there's fixtures that are going to aerosolize that water containing the bacteria, which then once passerbys or users of those systems get exposed to that, they can inhale the bacteria into their lungs, ultimately resulting in some form of legionellosis. Next slide, please. So the primary factors specific to Legionella growth within water systems are water age, disinfectant levels, temperature, and biofilm. And so the water age is something I'll get into a little bit more on the next slide here. Water age is a major factor in the water quality deterioration. Things that can increase the water age would be dead ends or dead legs. These are effectively pipes that aren't necessarily serving any fixture, or they're pipes that are serving a fixture, but that fixture is not being utilized. Low flow fixtures, so if a system was designed to handle a lot greater flow, and now you're utilizing low flow fixtures, you might not be seeing as much turnover that you would have typically seen if you were using those higher flow fixtures. You might not be scouring those pipes as well whenever you're running water, which can ultimately lead to biofilm formation. If you have excessive amounts of water storage to where it's just sitting for a very long time in there, as that timeline goes on, the disinfectant levels decrease, the nutrients from the pipe materials and other plumbing materials get added to that water and can increase, which provide an environment for the bacteria and ultimately food for that to grow. And I'm going to point out on this slide too, so this is actually from a healthcare facility, and I think a lot of, specifically in long-term care facilities, you'll see something very similar to what's in that picture, which is it was a shower room and they've ultimately converted it to like a nursing station or a storage room. Those pipes are still hooked up and those fixtures are still hooked up to the plumbing system, which means that they have water in them. And so if you're no longer utilizing that, that's something that's going to ultimately contribute to the water age. And that's something that we see very commonly, which is one of the reasons that I want to call that to each of your attention. Next slide. Disinfectant. So in this picture here, this is actually a supplementary disinfection system. But ultimately, once the water is coming to your facility, if you don't have supplementary disinfection, you're going to be receiving whatever disinfectant is within the system from the public water supply that you're receiving it from. And so the disinfectants added at the public water supply to try to protect the general public and to try to kill waterborne pathogens that might have been within that surface water or groundwater that they're receiving it from. But ultimately, you're given whatever you're given, and so you need to be making sure that you're moving water to maintain that disinfectant level. And even if you do have a supplemental disinfection system, you still need to make sure that you're moving water to get that disinfectant dispersed throughout. But ultimately, the disinfectant, the purpose of it is to try to control bacteria levels, to try to keep them from growing and reproducing. Next slide, please. And temperature is a large factor in the growth of it. We're primarily looking at hot water systems whenever we're going out doing investigations. That's the most common systems that are going to have Legionella growth within them. They are able to withstand temperatures of 122 degrees for several hours and can also survive temperatures below freezing. But really the sweet spot for the growth of that is between 77 and 113 degrees. and it grows best at 85 to 108 degrees. So we want to try to avoid those types of growth ranges. However, in a lot of systems, it's somewhat unavoidable in certain areas of it. Next slide, please. So when do we conduct environmental investigations at healthcare facilities? If we have one case of a presumptive healthcare acquired infection, or if we have 2 or more possible healthcare acquired infections. Next slide, please. So what does our environmental investigations of Legionellosis cover? So number one is based on the epidemiologic evidence that we have available to us. So with it being ubiquitous, we'd be searching for a needle in a haystack unless we have good epi information to be able to point us to the right direction. And so we do rely heavily upon that to be able to point us to the areas that we want to take samples of, because ultimately what we're after is trying to identify a potential source of exposure. We also are going to assess water systems to identify potential amplification. So if we see any areas within those water systems, similar to that photo that I showed where we've got a shower room that is no longer operating as a shower room, that it's operating essentially as a storage unit. If we see large volumes of water that aren't being utilized, if we see low census areas of a facility that are no longer utilizing water, those are all things that we're looking for in terms of trying to identify potential factors that could cause amplification. We'll review the water management plan, which I'll get into that a little bit more later. And then we also conduct environmental sampling when it's implicated. And so those sampling locations, we tend to try to collect samples from points of exposure, but then we'll also collect it from other locations throughout that system to try to identify the extent of the contamination if it is present. And then we also try to better understand water quality in general. So taking things like chlorine levels, pH levels, temperature levels, that sort of thing. Next slide, please. So one of the first things that we ask about whenever we go on is we go through the Legionella environmental assessment form. We don't necessarily use this form exactly, but we tend to ask all of the questions that are on that form. And so there's a QR code there for you to access it if you'd like. And this form is not really intended for the facilities themselves. It's more intended for the public health departments that are doing an investigation to ask those facilities. That being said, I would strongly encourage everybody to familiarize yourself with that form, because these are questions that are going to get asked. And so if you already have an understanding of all of the answers to that, it's going to make that process a lot easier if we inevitably have to show up on site and investigate something. And the other thing is we're asking these questions because they're important to the water management practices, and also important to understand whether or not that there's some form of exposure that might be occurring there. And so being able to answer those questions is also critical to being able to have proper water management. And so I do strongly encourage everybody to at least take a look at that. And then if you aren't familiar with the questions that are there, work with the water management team to be able to get answers to those types of questions. Next slide, please. So the environmental assessments will identify and describe risks within building water systems. So we will look at temperature, points of stagnation, disinfectant levels, external hazards, which I haven't really got into that a whole lot, but essentially what we're talking about with external hazards are things like boil orders, if there's been any kind of disruption to the water system, if there's water main construction going on, if there's any other construction within the building. And so a lot of times when we ask that question about construction, we tend to focus on the plumbing. That being said, any form of other construction, it can still cause vibrations within those plumbing systems, which can ultimately disrupt it, releasing biofilm, and can ultimately lead to exposures, which is the final thing that we're looking for, is points of exposure. So is there a fixture? Is there a device? Is there something that ultimately could have resulted in the individuals that we're investigating's exposure? Next slide, please. So we've talked a little bit about the investigation side. And so one of the things that we focus on is the prevention of it as well. And so the prevention is reliant primarily upon building water management. And so those water management programs identify hazardous conditions and take steps to minimize the growth and transmission of Legionella and other waterborne pathogens within that system. Next slide. Go ahead and go to the next slide too. And so for federal requirements of it, it comes from the CMS memorandum, and you can see the reference number here. which was released in June of 2017 and then updated and revised in July of 2018. And effectively what it says is that all healthcare facilities should have a water management policy in place that's going to be protective to reduce the risk of growth and spread of Legionella and other opportunistic premise plumbing pathogens. Next slide. Go ahead and go to the next one too. And so at the state level, in 2022, in response to some legislation, there were amendments to several of the administrative rules which regulate healthcare facilities, specifically the hospital licensing requirements, skilled nursing and intermediate care facilities code, and Illinois Veterans Home Code. And effectively what those requirements were to develop a policy for testing its water supply for Legionella bacteria. And that policy should include the frequency with which it's tested, and also the results of any tests and corrective actions shall be made available to IDPH upon request. In addition to that, that policy shall be based upon ASHRAE 188 guidelines and CDC's toolkits. Next slide, please. Minimally, the policy should also include a procedure to conduct a facility risk assessment to identify potential Legionella and other waterborne pathogens in that water system, a water management program that identifies specific testing protocols and acceptable ranges for control measures, and a system to document the results of testing and corrective actions. Next slide, please. And so this is just kind of a summary of ASHRAE 188. Effectively, it just gives you a good framework for what that water management program should consist of. Next slide. I'm going to pick up the pace, come realizing how far behind I am here. And the next is the CDC toolkit for developing a water management program. It was really built in conjunction with the ASHRAE 188 guidelines, and this provides essentially the framework for what that water management plan needs to consist of. It provides essential elements for that water management plan, and it really has does a good breakdown, has pictures, and it's pretty easy to follow, including worksheets and simple checklists to be able to simplify that process. And then more recently, the CDC released the Legionella Control Toolkit. Next slide, please. Sorry. The Legionella Control Toolkit, which is one that I've probably referred to more than any of them. It included actionable information on control measures to prevent Legionnaire's disease. One of the things we would always get asked is, okay, if we're doing testing, now what? This includes reference values, includes operational and design recommendations for specific building water systems, and also includes specific guidelines for mitigation measures should you end up finding Legionella within your system. Slide. So the water management principles in general, principles of an effective water management plan include maintaining water temperatures outside the ideal range of Legionella growth, preventing water stagnation, ensuring adequate disinfection levels, and maintaining devices to prevent scale corrosion and biofilm growth, all of which can provide a habitat and nutrients for Legionella. Next slide, please. And so 7 key elements of a Legionella water management program are to establish a water management program team. And the rest of these slides are pretty much providing a little bit more specific detail about this. And so I'll just go ahead and do that right here, just so we don't run out of time. But the water management team should really be consist of multiple disciplines. So it should understand the building water system. So typically that means that you're going to have your maintenance staff on board, but you're also going to have your clinicians on board. So your infectious control teams, hospital administrators, basically the people that are going to end up paying for anything that is going to ultimately be a part of that water management program. Describe a building water systems using text and flow diagrams. And so you have to have an understanding of how that water is going to move through your building and how it's being supplied to each one of the building water systems, ultimately to know where you need to implement control measures. And so having a diagram and making it clear and concise is the easiest way, because once you have turnover, those diagrams are going to persist. And so that's going to help inform anybody that joins that team after the fact. Identify areas where Legionella could grow and spread. And so that's pretty critical to being able to identify, again, where the control measures are going to be put in place, which is the next step, where those control measures should be applied and how to monitor them. And so what are we talking about when we're talking about control measures? We're talking about things like, where are you going to monitor chlorine levels, where are you going to monitor temperature at, where you're going to monitor pH, where are you going to collect your samples for Legionella. and establish ways to intervene when control limits are not met. And so once you've established control limits for those control measures, which are effectively your operating conditions, your minimum levels, your maximum levels, what you need to be operating within to be able to contain, prevent the growth and control of Legionella. So once those control limits are not being met, how are you going to respond to that? The plan should include concise language, basically detailing and informing the water management team of what response actions are going to be next. Making sure the program's running as designed and effective. It does no good to have a program or a plan put in place if it's not actually being implemented. And so what are the ways to do that? Utilizing logs is one of the most common ways. So logs for flushing, logs for chlorine monitoring, logs for temperature monitoring, logs for filter replacement, and ultimately document and communicate all those activities. So one of the common lines is that if it's not documented, it didn't happen. And so making sure that you document all of those activities. Hillary, you can go ahead and advance quite a few of these slides here. And then ultimately taking the water management program review. So once you have this, it's something that should be reviewed on at least an annual basis. And then ultimately, after any kind of incidents that might have disrupted the system or changed the system, or any incidents of disease that could be associated with it. And so CSTE has a really good water management program evaluation toolkit. Again, this is more so for the public health departments. That being said, it's a tool that we're going to utilize to be able to assess whether or not your water management program is complete and effective. And so it's something that that you can use to evaluate your own water management program as well. That being said, I think, is that my last slide? I believe so.
Yes. Thank you, Brian and Judy.
Thank you.
I have learned so much from you two as we work on these cases. So I appreciate hearing it all together, but I have learned a lot about the public health investigation for Legionella in addition to the clinical pieces. So we kind of wanted to round this out. We've alluded to some of this, but kind of wanted to round this out with a discussion of what else is in the pipes. And Legionella is the most common waterborne infection of premise plumbing that we identify, but there are other non-Legionella waterborne infections, for premise plumbing in addition to sort of other waterborne situations. And this was just sort of a cross section, and you can see like it's a schmutzy space. So in addition to some of the organisms that Brian mentioned, other organisms that have been associated with premise plumbing include serraceous species, other non-tuberculous mycobacteria, Pseudomonas species, Elizabeth kingiae, Stenotrophomonas, Pantoiae, Ralstonia, Acinetobacter baumannii. There are also premise plumbing has been associated as a reservoir for antimicrobial resistant organisms, in some cases like carbapenem resistant Enterobacterales or CRE and C. auris. So this is a paper from CDC colleagues called Investigation of Healthcare Infection Risks from Water-Related Organisms, and it specifically focused on non-Legionella, and they identified that potential water-related HAIs or healthcare-associated infections, excluding Legionella, so they were just looking at all others, water-related HAIs accounted for almost 22% of HAI consultations that their division received over a 4-year period. So it was just sort of an overview of this. The summary, point from that is that water is being seen increasingly as a risk for healthcare-associated infections and sort of extending beyond Legionella. So just have awareness of that. Not all times that these infections are identified in people, obviously they're not all associated, healthcare associated or, due to premise plumbing, but something to recognize. And probably the role of premise plumbing is underappreciated in infections, especially in isolated infections. I think there are sort of a number of different reasons that this is sort of increasing. Some is recognition and some are probably host factors as well. This is an image that I really like, that's potential transmission routes from water to patients. And, this is just sort of tracking all the different ways that patients that come in contact with water. And when we're doing one of these investigations, especially for these non-Legionella organisms, like we really have to drill down and think about all of the different ways that people can be exposed. So think about that as you're caring for patients as well, and all the different ways that they may be exposed and what risks there are and what you can take to mitigate that or make sure that there's a plan for that. In addition to sort of water management plans for premise plumbing, there are many other ways that people can be exposed to water. This was an interesting paper that was just came out recently, Aquatic Reservoir Associated Outbreaks of Multi-Drug Resistant Bacteria, a Hospital Outbreak Report of Pseudomonas aeruginosa in perspective from a Dutch national surveillance databases. So the thing that was interesting about this, they identified that contaminated sinks were a source for an outbreak in a Dutch ICU of a drug-resistant Pseudomonas. There was no interpatient transmission identified. So this wasn't being transmitted on hands, person to person that they identified, and sinks were identified as the sole source. Measures including contact precautions, intensified cleaning and hygiene procedures, retraining, installing and frequently replacing splash and aerosol, reducing inlets and faucet modifications failed to halt the transmission. So they tried many things to address this, and ultimately no new cases occurred after the removal of all water fixtures in the ICU patient rooms. This picture was not from there, but you can see sort of an attempt to block off the water so you can reduce transmission. So I thought that was interesting. It was one case of that where water really was strongly associated, and remediation involved removing those fixtures. And very recently, we're very excited to see this. So the CDC's Project First Line produced some new microlearns, and these are really quick learning resources that can be used in all healthcare settings to increase knowledge of infection prevention topics. And they produced these new microlearns one on water, one on sinks, one on drains, and one on ice. And encourage you to check those out and think about how you can increase awareness of the risks of water in healthcare with all staff across healthcare settings. And I just wanted to end with a little bit of a mention about our infection prevention program. If you're not sure what to do, who you're going to call, think about calling our RIP team, the Regional Infection Prevention Program. We are helping to rip out HAI in Illinois. And you can reach us at this email, dph.ip@illinois.gov. And this QR code takes you to the webpage that we have on the IDPH site for the Regional Infection Prevention Program. So whether it's thinking about water or other infection prevention needs, we are here as a resource. I realize that we're over time, so just go through these last couple quickly, and then if you're able to stay on, we'll see what questions there are. I think we've been trying to answer those in the chat. So next to come in the Fast Facts series on October 16th, there will be a presentation on respiratory season preparedness. We're starting to see respiratory illness ticking up. And in November will be travel and foodborne related illness. And there's a link to register here, which will also be shared with you. You can reach out to us in medical services via this form, and there's a QR code that will take you there. You'll receive these slides and you can access that there. And then if you haven't already, we want to just drive this home every time, please sign up for Siren. If this was shared with you via a route other than directly through Siren, please sign up for Siren. It's how we communicate with clinical colleagues, and you become aware of presentations such as this and other offerings, as well as new guidance and what have you. And this is the link for claiming CME credit as well. So I'll pause there, and then I am going to stop sharing so that we can see if there are any other questions, and I'll let the other presenters, if there are things that you want to address as well, say. I can't see them at the same time. I see that there are no. Yeah,
I
go
saw
ahead,
one
Judy,
maybe for Brian. Is it routine testing for Legionella recommended for long-term care facilities in addition to temperature and pH testing?
Actually, just getting ready to respond to that one in the chat. And so routine Legionella testing is recommended as a form of validation for those water management practices. That being said, it should really only be done as a part of the comprehensive water management program. And so one of the things we always say is if you test for it, you should expect to find it. And if you expect to find it, then you should have a game plan for how you're going to address that. And so we do recommend that. And one of the things that I kind of skipped over in my presentation, but I was going to get into a little bit of the types of testing that are available. So whether it's swab testing or bulk water testing, and then also whether you use PCR or culture testing. And then there's some other forms of like novel testing that they can utilize. That's ultimately up to the water management team to decide how they're going to utilize that. But culture is the gold standard for it, and then we do recommend utilizing CDC elite member laboratories. And there's a list on CDC's website that you can find one near you. As far as pH, temperature, and chlorine, we certainly recommend measuring all of those because they are common predictors for just general water quality, not just for Legionella, but for essentially all forms of water quality there.
And I'm more curious about this, so and apologize for being over time, but have we, so the question was about outpatient settings and do we also look for cases there, which we do. And we generally try to think of any exposures they may have been, especially those where water might have been aerosolized. And the hand sink is sometimes the only exposures that somebody might have washed their hands after bathroom use. And I know we had one that we suspected. Did we ever test a hand washing sink and find a positive?
Yes, we have tested hand washing sinks, and we have found numerous locations where they do have positives. And so just to kind of expand on that too, we've had investigations where the cases they're bed bound, they don't leave the room, they're getting bed baths the entire time. And so in those situations, if they don't have medical devices that might have water associated with them, their sources of exposure are going to be pretty limited. And oftentimes one of those sources of exposure is going to be the hand sink within the room that might be utilized by visitors washing their hands, by staff washing their hands. And oftentimes that might be the only thing that seems to be plausible other than potentially outside exposures coming into the ventilation system.
Thank you. I think, oh yeah, go ahead, Judy. Did you have anything else? You've been monitoring the chat more closely than I've been.
No, I think we got everything. People are asking for the links to the microlearns, and I think those will come out in the slides then, if they get copies of those.
Correct. Those will be in the slides. Great. Well, thank you both for presenting with us, and thank you for everybody for attending. If you have additional questions, you can reach out to us at Med Services or for infection prevention questions or assistance at the dph.ip@illinois.gov. Thank you all. Have a good afternoon.
Thank you, guys.